Okay. All right. So I'm going to record this so we can share on our, we have a ISU OTA YouTube page. So we have all of our former Journal Club recordings on there. We have some really great topics. I'm super excited about our topic today. But before we go into introducing Julia and our topic, I did want to put a bug in people's ears because we usually break Journal Club over summer unless someone wants to volunteer to spearhead it. If not, then May 2nd is a Tuesday, the first Tuesday in May. So we'll pencil in May 2nd at 6:30 p.m. Topic is to be determined. So if anyone has something they would love to present on, or someone they would like to volunteer to present, or a topic that they would like to hear about that we can kind of dig in, and maybe I could find a research article or something. My whole goal is to make this relevant to people. I think this topic came about from last month's topic, just discussion, and somebody had requested this. So I want to make it where it's fruitful for the people that are coming, or something that'll get more people to join, just to keep this growing, because I do think that this is an asset to our profession and to our region and beyond. So Julia Sanders, an OT at Portneuf Regional Medical Center here, or I guess Portneuf Medical Center, is that what it, PMC, here in Pocatello, Idaho. She is going to talk to us about stroke interventions. So Julia, feel free to, this is your platform, so share what you would like to share about yourself and your topic.
Okay, so I have been at Portneuf for about just over 8 years now, and I started in rehab, worked with a lot of patients that have had a stroke, and now I'm on the acute floors, pretty much doing the same thing. I've had lots of students, and I was excited to have this topic to be able to discuss with you, because I do think that I have a fair amount of knowledge and experience here. With that being said, I will also say that once I started to really dig into it, I thought, oh gosh, what do I do? Because there is so much. No stroke is the same. No patient is the same. So I am going to work on sharing my screen with you guys and start our show. Maybe. There it is. Okay. So stroke interventions, right? So just a really quick rundown of what we're going to talk about. I'm going to give you a super brief background on strokes. We are going to look at a lot of evidence-based practice and research articles. And then we are going to do a group discussion on what interventions could we use, what have we used, what have we seen that works well, what doesn't, or what maybe did not work, but might work for somebody different. If there is absolutely nothing that you take away from this presentation except for one piece of information, I highly recommend going to look at the AJOT issue 69 from January, February of 2015. That is where I got the bulk of this research. I did see that it's maybe, I don't know this for a fact, maybe AJOT just put out a newer version of what they did in 2015, but I'm not 100% on that. So 2015 was kind of my go-to. So on the background, so stroke is the leading cause of adult disability in the United States, and there are more than 7 million survivors of stroke. The limitations in ADLs remain high for stroke survivors in the long term, and that is correlated to overall life dissatisfaction. Motor deficits specifically are the most common and the most challenging consequences of a stroke. There was a longitudinal community-based study, 108 participants, they all had an ischemic stroke, and it found that 50% had hemiparesis, 30% were unable to walk without assistance, and 25% were dependent for daily for ADLs. So, and I did not read every single article that I am showing you guys. I take that back. I did not read every article that has been referenced, but the ones that I did read, it'll be very clear. So here we go with the articles. So this first article was kind of the platform that started everything. Glenn Gillen wrote an editorial for AJOT asking the question, what is the evidence for the effectiveness of interventions to improve occupational performance after stroke? They being AJOT and AOTA, they had a huge mandate to try to make everything more evidence-based. And they had teams of researchers to review evidence and determine the effectiveness, basically of 4 different categories. Interventions to improve occupational performance for those with motor deficits after stroke, with cognitive deficits after stroke, with activity and social participation after stroke, and psychological and or emotional impairment after stroke. So after they did a review of over 12,000 abstracts, and they include 274 articles in their final review of those 4 topics, they learned a few things. They learned that among ischemic stroke survivors aged 65 or older, the following disabilities were pretty common even 6 months after stroke. 50% had hemiparesis, 30% were unable to walk without some assistance, 46% had cognitive deficits, 35% had depressive symptoms, 19% had aphasia, 26% were dependent in ADLs, and 26% were institutionalized in a nursing home. So another thing that they learned is that a lot of occupational therapists use cognitive measures outside of the context of occupation. Most commonly things like cancellation tasks, memorizing a string of numbers, or making trails. So these are either things that are pen and paper, or there's just nothing else involved in the task. Of concern also is that we as a profession need to embrace occupation-based cognitive assessments and interventions to demonstrate our unique contributions. After reviewing all of these articles, they also found a large randomized controlled trial that NDT, or neurodevelopmental technique, was inferior to meaningful task-related training. NDT is the most frequently used among OT interventions across all settings for stroke, myself included. 85% of OTs use NDT and Brøndström's movement therapy as their preferred approaches. And one of the things that they also noted was that Brøndström's approach was last updated in 1992 and cited abstracts and references from 1898 up to 1960 to support it. So I'm not going to say that means that it's not effective, and I'm not going to say that it is not worth using, but the research needed to be updated. The other thing is, as we go through some of these other articles, you will see that we are absolutely narrowing our own scope of practice as occupational therapists, because we are, quote, ignoring parts of the framework. Occupation, social participation, and interventions for people with emotional impairments received the least attention in the research and the literature. So it is essential to our holistic perspective that we work towards changing that. The next article looked specifically at preparatory interventions. So there are certain interventions that can absolutely support performance in ADLs, but we really want to look at task-oriented training or occupation-based things when we're doing our practice. This systematic review presented multiple preparatory interventions for adults that had had a stroke and showed the effectiveness. So I can't remember how many articles they reviewed, but early mobilization, passive range of motion, and sensory retraining all showed moderate strength of evidence to improve or increase ADL performance. Shoulder taping, bilateral priming, and early supported discharge all demonstrated low strength of evidence to support ADL performance. This article had to do with motor impairments. I did this slide a little bit differently because I thought it would be easier than just a whole bunch of words on a page. So this research team looked at 149 studies. That is a lot of studies. Please don't count the numbers there. It probably doesn't add up to 149. And I do admit, going through this article, I got a little bit fuzzy on a couple of the details. But according to this review, task-oriented training might be considered the foundation of interventions focused on improving occupational performance for those with motor impairment after stroke. However, there's all of these other interventions that can improve occupational performance as well. So if you kind of look at the numbers here, repetitive task practice, 4 out of 6, that's a pretty good number. Whereas mental practice, 3 out of 7 had positive results from their study. That's less than 50%. Again, it doesn't mean that it's bad. It's just, this is what the evidence has been showing. And then while they were researching this, they decided, let's just throw in some of the other information that we found from doing this research. So some of the interventions utilized are not just good for activity and participation, but they helped to improve balance, mobility, upper extremity function. I thought it was really interesting that when it comes to action observation, there were two studies that showed improvement in upper extremity function specifically for chronic stroke, but only one of them for acute stroke. Our next article specifically looked at psychological and/or emotional impairment after stroke. So as many as 50% of stroke survivors might experience a stroke-related psychological or emotional disorder, the two most common being depression and anxiety. In general, other stroke-related psychological impairments, they can be difficult to distinguish from depression or anxiety, and those include things like affective and mood disorders, post-stroke emotionalism, behavioral and personality changes such as anger, irritability, apathy, sexual changes, and obsessive compulsive disorder, cognitive and behavioral disintegration, such as acute confusional state and delirium, and perception identity disorders of self or of other people and places. Now that one specifically, perception identity disorders of the self, they have been linked to unilateral spatial neglect. And so for the purposes of this team's review, they decided to consider perception identity disorders a cognitive disorder. They looked at 39 articles describing 38 studies, and they found 6 themes that arose. Exercise or movement-based interventions. And this got a little bit heavy. There was a lot of information here. So in short, the evidence is insufficient to support or refute the efficacy of providing a single component exercise intervention to improve depression, anxiety, or mental health related quality of life after stroke. Those might be things like bilateral upper extremity tasks, ergometry, progressive resistance training, Tai Chi, or treadmill walking. They also found that the efficacy of multi-component exercise programs is inconsistent across studies. Those might be things like strengthening, balance, range of motion, or endurance exercises. They looked at behavioral therapy and stroke education as a combined intervention, and it showed that there is insufficient evidence to treat depression or anxiety or mental health related quality of life. They looked at behavioral therapy only, and they found that there actually is some support for problem solving therapy and motivational interviewing to treat depression. Adversely, for stroke education only, they found that there's mixed evidence to treat anxiety and not sufficient evidence to treat depression. They looked at care support and coordination and found inconsistent evidence. And lastly, they looked at community-based interventions that included occupational therapy. Again, this is one that got a little bit heavy, deep, detailed. So an intensive multidisciplinary intervention was defined as 6 or more home health visits, and that showed significant differences for the intervention group in mental health related quality of life, depression, and anxiety. However, they also did a study with occupational therapy directed program so there was an OT and a recreation therapist. They addressed leisure, and it found to improve depression, but not mental health related quality of life. There were 3 other studies that were like a day program, and those did not show a significant difference of those 3 factors that we've been talking about between the intervention and the control group. So in short, what they kind of found out of the community-based one is there is some evidence that more home health visits for people that have had a stroke might improve their mental health related quality of life, their depression, and their anxiety. And as a profession, as an individual, we need to recommend more visits. We need to advocate for our patients in that manner. This article looked specifically at task-oriented training with the use of cognitive strategies. I thought this one was really interesting too, just FYI. So stroke recovery requires significant repetition of movement for improvement of motor function and ADL performance. But not surprisingly, patients that have had a stroke have a limited amount of movement to achieve that repetitive training. Maybe that's because they are too fatigued. Maybe that's because we are not by their side all day. Maybe they don't have the family members to support them and keep them going. There's a myriad of reasons why it is really hard for them to do that. But the nice thing is we have these cognitive adjunctive treatments. They are inexpensive, they are safe, and they require minimal labor from you and from the patient. They can be used to increase the movement practice. They can facilitate neuroplastic changes in the brain, and they can be implemented at all stages of stroke recovery because there aren't any actual movement requirements. It is all mental. So after doing their review, this team found that action observation with task-oriented training showed moderate evidence to improve ADL performance and functional mobility in the acute and the subacute stages of stroke. they found that mirror therapy combined with task-oriented training showed strong support for ADL performance and functional mobility at all stages. And they found that mental imagery and task-oriented training showed moderate evidence at all stages, but only for short-term functional mobility interventions. So everything that is less than 6 weeks, 6 weeks post-stroke. Just a couple more, guys. This article specifically looked at cognitive interventions or cognitive impairment. There are estimates of the incidence and prevalence of stroke, but those numbers vary greatly. They think that it's because of the variability in diagnostic criteria for cognitive impairment, the phase of recovery when assessment is done, and the sensitivity of assessment tools. When they did this, they looked at 46 different articles, and they found 7 different themes to emerge. The general cognitive, for general cognitive deficits and cognitive remediation, they looked at articles that included cognitive remediation therapy, story retelling, cognitive enhancing games, and aerobic exercise. And that found that evidence supports the use of these strategies to improve global cognitive function for all individuals, as well as visuospatial training post-stroke. There was evidence to support an individualized home rehab program. Oh, excuse me, there was not. There was insufficient evidence, excuse me. For executive dysfunction, there was limited evidence supporting the use of time pressure management strategies to improve the speed of daily task performance for adults with slowed processing speed. They also use something called the V-Mall, which is a virtual supermarket, and they had limited evidence for multitasking and improving executive function and memory. For apraxia, there was evidence to support techniques that include internal rehearsal, verbalizing action during ADL execution, and external cueing. There was a gesture training group in one of the articles, and they demonstrated significantly improved performance despite having ideational, ideomotor, or gesture comprehension. For strategies and interventions specific to memory loss, there was limited evidence. For attention deficit, there was insufficient evidence. For visual field deficits, and these were included because of their close relationship to neglect. There were only 8 studies that they were able to include in their review. And those studies use interventions like compensatory exploratory saccade training, perimetry training, Dynavision training, computerized visual perception training, audio-visual training, and a systematic treatment program to restore visual deficits. Honestly, if you go through every single one of those 8 articles, they were different. Some of them found support, some of them did not find support, insufficient, limited. There really wasn't anything that had good evidence behind it. Additionally, a lot of those studies had low numbers for the population that they were looking at, or sometimes the limitation was that the methods used for the interventions or for the study themselves were not as sound as they would have liked. I highly recommend you just read that one yourself. if we want at the end, I will read all of my notes on it, but it's like a whole page of notes just for those vision ones. Okay, and then the last category or theme that the team looked at for cognitive impairments was unilateral neglect. In short, it was inconclusive of which approach could potentially be utilized. They looked at 23 different studies. And interestingly enough, I can summarize the 23 a lot better than I can summarize the 8. So the cognitive interventions that were used included protocols, structured therapy, computerized therapy, the prescription of aids, not people, but devices, and modification of the environment. They focused on prisms, on visual scanning training, mirror therapy, right half-field eye patching, neck muscle vibration, family participation, and spatial cueing with limb activation. This should be our last article to review. And this one specifically looked at activities and social participation after a stroke. After reviewing 39 studies, 21 of which addressed ADL performance, 12 addressed IADL performance, only 3 addressed leisure and social participation, and only 1 reviewed rest and sleep. These researchers showed that, or decided there was just an overemphasis on ADL performance. Of the 21 that addressed ADLs, most of the studies were done in inpatient rehab or outpatient, and they either did not support or had limited support for the use of occupation-based interventions over the control group. There was, however, a significant amount of evidence supporting the use of occupation-based interventions to improve ADL performance in the home health setting and the community setting. The 12 studies that looked at IADL performance did not provide sufficient evidence in inpatient rehab or in outpatient, and there was only limited evidence to support the community setting. Of the 2 randomized controlled trials that looked at leisure, as you can see here, there was limited evidence for the day program focusing on leisure activity to improve self-rated ADL and IADL performance. But there was improvement on the self-rated performance and satisfaction across self-care, leisure, and productivity. Now, I have no idea how they categorized limited evidence on self-related ADLs versus improved performance on self-care. ADL, self-care, ADL, self-care. I don't know why they said one was limited and one was improved. That's how they wrote it. The other leisure study showed moderate evidence for a home-based program, improved self-report of participation and satisfaction in leisure pursuits, significant increases in satisfaction, in time spent with the activities, and in the total number of activities performed. For social participation, there was no significant increase in reported performance of self-care, leisure, and productivity. There was limited evidence using the chronic disease self-management program, and there was moderate evidence for using co-op with a remediation-based usual care group. So significantly greater improvements in the intervention group. The one trial that did look at rest and sleep, not enough evidence. So they summarized the the findings by saying four different things. The evidence supports the use of occupation-based interventions to improve occupational performance after stroke. The majority of evidence supports interventions targeting ADL performance. The evidence related to IADL performance is disparate and more difficult to draw definitive conclusions from. There is limited to no evidence supporting occupation-based interventions to address other areas of occupation beyond ADLs and IADLs. And there are several of the studies that were preliminary or had methodological issues that limited the generalizability of the findings. So just like I said before, some of the studies that they looked at might have been really good, but the numbers weren't high enough, or there was just some limitation and flaw that kept it from being maybe moderate or strong evidence. We don't know at this point. Just have to do more. And like I said also before from Glenn Gillen's editorial, if it's not an ADL or an IDL, we kind of don't know. So after looking at all of those things, what do we actually know? What can we utilize? So these are not the only articles in the world for OT, for stroke. These are just the ones that were presented today. So what actually has strong evidence? Occupation-based interventions, specifically for leisure, and repetitive task training. When we look at moderate evidence, we have a much bigger toolkit to pull from. Early mobilization, passive range of motion, sensory retraining, occupation-based interventions specifically for ADLs, task-oriented training with the usage of a cognitive strategy, CIMT or modified for upper extremity function, and then for depression, either problem-solving techniques or motivational interviewing. That's a lot of information. And it's not where I thought this presentation was going to go. But now I want to open it up to you guys. We're going to look at some of what works, and we're going to kind of compare it to what are some of the problems, the deficits that we generally see with our patients. So if we have a patient, and it's going to be different for whatever setting you're in. You know, what I do in acute care is going to be different than what somebody in home health does, different from what we do in the community, different from what we do in skilled nursing or inpatient rehab, different from what we do with somebody who had a stroke 5, 10, 20 years ago, and they now need some kind of remedial training perhaps. So I just want to open it up to everybody. If you had a patient come into your setting and they had balance problems, sitting balance specifically, what can we do as practitioners to intervene and help that patient?
Hello. I am a CWI student, and I'm currently I'm doing my level 2 fieldwork at St. Al's. And so I tuned in because I'm seeing a lot of stroke patients there. But for like sitting balance specifically, obviously the severity varies a lot. But we definitely have been, sometimes it's just working on them maintaining their balance just sitting without doing anything and seeing if we can establish that. And I don't remember what this is called, but I learned something cool last week where if the patient is leaning one direction, if you have them put all their weight on the other side of their body and like lean onto the bed, sometimes it like helps create an equilibrium there. And I was trying to think of what that would fit into. So that's like a severe case, but my immediate thought also is we do a lot of bedside ADLs and grooming. So that kind of fits with some of this stuff too.
Absolutely. Great answers, Katie. I would probably say you're either talking about weight bearing on one arm,
Mhm.
or the terminology sometimes used is pusher syndrome. So if you have somebody whose left
This is
side
why
has
it
been
seems I have to
affected.
like make an appearance. You know?
Hi, Lisa. If you have a patient whose left side has been affected, but they are leaning into that direction, you might find that they have pusher syndrome. And one of the things that you can do to help correct that, you're right, Katie, is we lean towards the opposite side, so towards that unaffected side. The thinking behind that is your patient doesn't know middle is here. They think middle is here. And so that's where they want to be. And when you go too far into the opposite direction, they feel like they are falling. And so it is helpful to, explain to them, educate them. This is not middle. This is middle. Yeah. So those are good strategies.
Which is why that's often called midline orientation deficit, which is synonymous for controversive pushing or pushing syndrome. And then I think along with that, I mean, the thing that I try to get people or, my students to look at, and the thing that I think just our OT brains naturally go to is, I mean, there's so many different things that are strong evidence, little evidence, clinician specific, where it's like, if you're sitting, especially acute care, where it's like, you're doing sitting balance, you're looking at that midline orientation, you're looking at, can we incorporate weight bearing? You're looking at, visual attention, you're looking at ADLs. I mean, like, that's the thing of like a simple grooming activity, sitting edge of bed, and then just a few ways to adapt the intervention, that intervention just became incredibly powerful, where I think that's probably why it's incredibly hard to like study and quantify what actually is strong evidence and what's not, because every patient is so different. But then also there's just so many factors that go into the intervention design and the execution and then the response. But I think that's the fun and exciting thing of just, to a lay person, it looks like we're just having them wash their face, but it's like, we are looking at so much more. And then obviously the intervention can get far more complex and like focused on one specific thing if it needs to be. Like we're probably out of acute care now, we're in rehab, and I'm looking at like, what are the specific techniques to try to facilitate neuro re-education in a hemiparetic arm that has sensory loss and there's inattention, or all of these other things. Just my 2 cents. Okay, so I'm going to read Allie's comment. She said, I think also using motivational interviewing while you're doing more straightforward physical activities, just to engage with them and hopefully attempt to address emotional problems as well. And I agree with that. Like, I liked how your research review talked about the emotional side, the social side. Like, that's a huge part that we should certainly not be neglecting.
Right. I agree. I want to go back to the balance and the interventions here. One of the things that I like to do fairly early on, obviously patient dependent, is I like to have my patients reach towards the floor. I think there's something about having them like fold over on themselves and then work on pushing up that helps them achieve that midline more, maybe not more so, but in a different way than leaning laterally or weight bearing side to side would. It also, I think, helps them realize that the floor is not as scary as they think it is. Like, they're scared of falling. We absolutely understand that. But if we can help them understand, A, we're going to keep them safe, and B, they have more abilities and capabilities than they think they have, they will try more. Generally, they will be more motivated to attempt those scary things, because we can refer back to, remember when you reach to the floor, things like that. What about for patients with spasticity or hypertone? Have you guys read anything or done anything for patients in this category?
I'm gonna butcher this because it's been a while since I've used this technique. So it was interesting that NDT is less supported.
I know.
Because it is still heavily used. And then there's an offshoot that I'm not familiar with what the research is saying about it. But so when I was at St. Luke's in Boise, a lot of us therapists were going through neuro-IFRA training, and I don't remember what it stands for, but it's an offshoot of NDT created by an OT. And then it's interesting, just in the position I'm in now, where I do all the site visits for the fieldwork coordination. There's a site down in St. George, Utah, that their inpatient and their outpatient neuro wings are all neuro-IFRA trained therapists. So it's pretty, I mean, it's a cult of a therapy group in a sense, because like it is very, very specific. And so I just did a site visit with one of my students who's doing an outpatient neuro rotation, and just how obviously it's a different thing for her because she hasn't done the training, and there's nuances of who can do what and what they can tell and whatever, because it's very copyrighted. But I just think when I did my first site visit down there, it was pretty interesting just seeing a little bit of the treatment where it's PT and OT working together, just really maximizing who has what strength as a clinician, but just looking at whole movement and minimizing any form of compensation, any form of something that would elicit spasticity, which is kind of cool because you think about like a traditional sense, like I just did this great, whatever, using different strategies to manage spasticity and normalize tone. And then they go walking down the hall and their arm is up here, in a matter of 10 minutes. So I think the philosophy is super cool, but it'd be interesting to dig into the research, because I think that's one of the hardest things to really deal with long-term, of like, Botox. I know we were doing Botox with a protocol to get into OT right away, to get the Bioness on them, to really get that active range of motion through the eStim or the FES, to then maximize the benefit of the Botox, and then obviously work on that retraining, because it's obviously the Botox is effective. The hard part is getting the neuromuscular reeducation to occur, so that by the time that Botox wears off, the person has proper motor control, activation, and then adequate strength to override the muscle group that is spastic. And that's the challenging part, because that is a really uphill battle. But anyway, I just thought the little bit of exposure that I have to neuro-IFRA, when it's done in that, like, every single clinician is living and breathing this, and that entire patient's day is all normalized movement with minimal effects from spasticity, it seems pretty cool. And so I would love
Brittany, yep. I Googled it. It stands for Neuro-Integrative Functional Rehabilitation and Habilitation. Neuro-IFRA, IFRAH.
Yes.
Copyrighted, Waleed.
Yeah.
Somebody is who developed it.
And they do, like, this is something that as organizations, I know like St. Luke's was getting on that bandwagon of bringing courses in and training their therapists, where I think facilities as a whole, other places, could advocate for bringing those courses in, getting those trainers, and then training, and then starting to use that as a culture of rehab, which maybe not obviously the acute care, but I think some of those settings like St. Al's and St. Luke's and Boise, it makes sense. But why not here in Eastern Idaho too?
Yeah, well, we do have inpatient rehab. I will say I had never heard of that until I started doing this slide deck and presentation, and one of my PT counterparts used to work in Reno, and she mentioned this to me. I know that like 2% about it, 0.2% probably. But I will say, when she looked it up on the internet, one of the things that we found was, or one of the things that we questioned was, where is the research? Again, not saying that it's wrong, not saying that it is not effective, because it certainly sounds like it is. But if we're going to be an evidence-based profession, we got to do the research.
And I think the course is like, I feel strongly that there has to be some research, but is it strong research? I'm not sure. But again, you know, like you'd think that research should be out there in the public, but I do think like from 2015, well, yeah, I mean, because I left St. Luke's in 2016 and I think I did 3 neuro-IFRA courses. So it should be out there in these kind of meta-analyses looking at effectiveness, but it'd be interesting to dig more into that specifically. But I feel like they have to have research, but I don't know. And is it strong? Interesting too that constraint was in your moderate research, but then what, like repetitive task training was in strong, which to me it's like, aren't those the same? It just doesn't have the buzzword of constraint, or maybe it's not the like design of constraint. But like even just, you know, like 10 to 15 years ago, constraint was like, this isn't effective, or there needs to be more research. So it's cool to see it improving. But it's just, research is so fickle. And I think in the neuro populations, yeah, it is also like, it's just hard to really pin down to show strong evidence.
Yeah, absolutely. Absolutely. And just because strong evidence works for one patient doesn't mean it's going to work for another patient. Let's try to get back into our intervention discussion kind of, and maybe what we should do is abandon this list a little bit and hear from the other people that are here with us. Like, have you had an issue that you have seen, or you don't know where to start with a patient? Like, talk to us. That's why we're here.
Can I read this comment from Michelle?
Sure.
It steers us in a different direction. So she said, given that the OT framework added health and medication management in 2020, something I've started doing is at the time of acute eval, I ensure the patient understands what a stroke is and discuss all of the deficit findings to incorporate more of a collaborative problem-solving relationship, and then ensure they understand neuroplasticity and the necessity of force use and mass practice, which I 100% agree on. And then let's see, Cameo said, I know things are short, but I had a stroke patient in my fieldwork after acute care. We did joint approximation 3 times a day. So another strategy for proprioceptive input, sensory retraining following neurological injury. Good deal.
Nice. So I did do a quick list just for myself in case we had a lull. So when it comes to speaking, if a patient has problems with either aphasia or dysarthria, one of the things that I like to do is I just ask them lots of questions. I mean, not so much that the session is necessarily overrun by me just talking. But especially if I have some kind of family members present or caregivers that I can get a little bit of information from them. When I have those prior military patients, I always try to ask them, what branch did you serve in? What did you do? Where were you stationed? And sometimes in asking those more personal questions, you'll get more answers, or at least attempted answers. And they'll try to involve you, because I mean, the military is a big thing for a lot of people, or asking about kids or grandkids. That can be a really good carrot to get somebody talking. And it's a heck of a lot more fun than, okay, what is the word for this thing in my hand? This is a toothbrush, versus, I was stationed at Camp Pendleton and it sucked. And I had to go to Vietnam and blah, 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 blah. Like way better. Has anybody else done anything intervention wise for aphasia or dysarthria? Okay, then we're going to move on to eating. I know our time is getting pretty short, so we're going to run through things. For eating or self-feeding, hand over hand, adaptive equipment, those can be really helpful for your patient. And for Pete's sakes, especially if you're in an acute hospital, make sure that your patient is sitting in a position that will actually foster them moving. I can't tell you how many times I've been into a patient's room and the nurse tells me, oh, they're a one-to-one feeder. Well, yeah, they're going to be a one-to-one feeder if they're sitting like this and they're on either their affected or their unaffected side, and they just can't get to their tray and their food. So positioning can be a really big part of eating. Any other comments on eating?
I echo that. It drove me nuts having them with their bed reclined, the food way out in front. They can't even sit up. And, you know, let's put them in a chair and have them in a proper seated position for safe swallowing. And even having someone there to not feed them, but cue them so that they're able to engage in the activity. Yeah.
Absolutely.
I think too, I love the sensory components of feeding and eating. You know, if we have a huge crowded dining area versus a quiet space, and I mean, we talk about this with dementia, but I think it has to do with this kind of success as well. Why set them up to fail? And remembering too that feeding and dining are such a cultural part of our culture, I guess. And so it's an important part. And if we're not, you know, and if we can't participate in it, and also looking at the different types of foods that people find important.
Mm-hmm. So not hospital food, generally speaking.
Or pureed everything on a white plate, on a white tablecloth.
Yeah.
I think also you can bring in the spiritual component too. Like, do you want to pray? Maybe they haven't thought about that for a while.
That's wonderful. All right, let's move on to upper extremity. So shoulders, elbows, wrist, digits. Oh my gosh, there's so much. I'm going to pick on somebody who hasn't talked yet. Megan. Yeah, you.
Well, I'm just a student, so we haven't actually learned about stroke yet. So like all this is like a lot new information. So I'm just trying to keep up the best I can.
Okay. Well, take a wild guess. Just guess. What would you maybe do?
For shoulder, elbow, and wrist and digits. Ooh.
Yep. So any of the above. It doesn't have to be everything.
Oh man, I mean, just participating in like functional ADLs. Man, I don't know. You really put me on the spot.
No, that's fine. Functional ADLs, that is task-oriented ADL performance. That's where we put our emphasis, right? And I don't think there's necessarily anything wrong with that. So it might be something as simple, quote unquote, as let's grab a cup. It might be utilizing that arm for feeding. So now we have digits, wrist, elbow, and shoulder all at the same time. Combing hair, brushing teeth, bilateral tasks, opening up that toothpaste, opening up a package. When I have a patient in the hospital who has had a stroke acutely, one of the things that I might do is I hand them a package of socks, those grippy socks that everybody wears. Can they open it? I don't care I mean, if they can open it, great. If they can put their socks on, great. But every little thing that I hand them or give them is a different way to assess and intervene of their upper extremity deficit. You know, maybe there's somebody who is functionally mobile, they're getting around in the hallways, and they just lack strength in their arms. Maybe one of the things that we can do is, all right, Jack, we're going to take your food tray and put it back into the food cart together. Maybe it's, all right, buddy, we're gonna go and refill your water because you want water and you are on thin liquids. We're walking down the road. I want you to push the little buttons, boop, 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 to get into the room. And you can hit the buttons yourself to get water, ice, etc., etc. Please don't call infection control on me. Also, I don't care.
Yeah, I guess we're working on like SOAP notes right now. So we recently just watched a video with a stroke patient working on meal preparation. So that was interesting to see the OT kind of guide the patient, assist the patient. So yeah.
Nice.
I know at one point I was digging through a meta-analysis on stroke interventions that were supported, and my brain always goes to using electrical stimulation, and so FES is heavily supported in the research, and I feel like that's an easy way of tying, you know, obviously rehabbing the upper extremity, whether it's a strength component, an initiation of movement, or just getting that return of activation, whatnot. So I like eStim. And then I know that we had a therapist that was really good with mobile arm supports for the spinal cord population, but it was really applicable to the hemiparetic population as well. Especially like setting them up where they had more independent feeding, if they had some proximal movement, to be able to use that distal support with a mobile arm support. So there's some cool tools that we have, external devices that can build up the function that they have that are applicable to the upper extremity.
Yeah, that's super cool. One of the other things that I sometimes like to use for patients who have little to no shoulder or elbow, or a combination, is there's this thing called an arm skate. And at least ours is blue. I don't know if they're all blue or not, but imagine like a little skateboard. And on one side, there's a grip for your hand. And then there's some Velcro to keep the hand in place. And on the bottom, there are actually little wheels. And so you can position, I'm going to move my computer here a little bit. You can position your patient against the edge of your table and see if they can do any motions, you know, do like a windshield wiper, go back and forth, whatever, reach for that cup, reach for the handkerchief, reach for whatever. I think arm skates are really cool. And when I was on rehab, I used them pretty frequently. Okay. What about sitting versus standing activities? What can we do with our patients in sitting? We already talked about this one. Look, go ahead, Lisa.
Oh, I was gonna say, I don't know if you're, trying to get at this or not, but I mean, there's benefit to having them stand, but there's benefit to having them sit as well, because you're changing the task demand depending on where. I mean, you could do functional reach with the upper extremity, whether you're in sitting or standing, but it's whether you want to add that, dynamic balance component or that endurance component, or if you want to eliminate that to just focus on the arm. So it's just a matter of trying to figure out what is your patient up to and what are they, what's the benefit.
Yeah. The other thing is, sometimes we need to do sitting versus standing to give our patient that just right challenge. Maybe they can do pretty well grooming and hygiene at the sink while they're sitting, but they're not ready to do that in standing yet.
I think too, also to go along with that just right challenge, giving them that success. So if they're frustrated because they can't do it standing up, showing them that sitting down, increases that success might be enough to help them jump over that hurdle, psychosocially.
Absolutely. What if we have a patient that has a subluxed shoulder? The dreaded sublux. What do we do?
I mean, I think isn't it still encouraging them to use the shoulder, but you're supporting the scapula?
Mhm.
I haven't gotten to do that yet, but.
Yep. So prevention is definitely key when it comes to a sublux shoulder, because there's probably numbers on it somewhere. I don't know what they are. I'm just going to say it is 1,000 times easier to prevent a sublux than it is to remediate it. I have done taping for a sublux shoulder before. I don't know how beneficial it is. Some patients like it, some people don't. There are sling immobilizers that can help, like a Give More sling or an Omotrain sling. Positioning with pillows, education, so much education. The patient, the caregivers, the family, whoever is involved in that human's life, educate.
Can you just tell me how that happens, the sublux shoulder after a stroke?
So this is not going to be a very pretty anatomical description. What I normally tell my patients is it's like your shoulder has dislocated and the muscles don't have the strength to help keep that shoulder where it's supposed to be. So the problem is, I'm going to turn sideways just a little bit. The problem is what you'll end up finding is there will be a little divot right about here. It's called a sulcus sign. And at least when I have patients in the hospital, if I think that's a possibility, generally it's going to be with patients that are flaccid, like flaccid. So what you do is you actually take your hand at the bottom of their, or just proximal to the elbow. Yeah, just proximal to the elbow. And then you give it a little pull downward. And with your other finger right here, you see if there's like an opening, if that sulcus sign gets just a little bit bigger. I am told it doesn't hurt. They don't know. But it is a good way for you to quickly assess, and then you go into prevention, intervention, education mode, like immediately. You're welcome. Okay, Brittany, are we already 10 minutes over?
Yeah, I would say, I mean, this is good discussion, but I would say maybe we can wrap it up for the sake of everyone's time. If maybe open it up to questions, or I don't know if there's anything you want to just summarize about the last few on here.
Sure. So Pisher syndrome, I think we've already kind of talked about weight bearing side to side. Also using a mirror in front of the patient can sometimes help, giving that visual feedback, another way to look at things, no pun intended. Moving into vision, some of the things that I have done with my patients, this is just in the acute setting or in inpatient rehab. We have pictures in our hallway. Let's walk down the hallway, turn your head side to side. Let's scan. Tell me what's in those pictures. What do you see? I'm going to give you more questions about those pictures. Can you find what I'm looking for? Can you answer my questions? I also have like full page letters and full page numbers that I have placed randomly in the hallways, specifically in rehab. And they're out of order. So as the patient is walking, I want them to scan left and right. Are they finding the numbers in order? Are they missing everything on the left, 50% on the left, whatever that case might be? And then for cognition, oh my gosh, there's just so many things. I wrote down a couple of things. Predicting and rating performance. So have the patient actually predict, how are you going to do on this task? How did you do on this task? Is there any awareness, or are they completely oblivious into their impairments and deficits? Having them verbalize a task before they try it. I love co-op for patients that have more cognitive deficits versus the physical deficits. I think it's a great tool to keep in your pocket. Lots of assessments, lots of just random little things here. Also, I haven't been able to do this in the first 7.5 years at Portneuf, but I now have a speech therapist that likes to co-treat. Co-treating with speech therapy is super fun because, I mean, we co-treat with PT all the time, but speech therapy is a totally different ball game. So there you go.
Cool. Awesome. Thank you so much, Julia. I think
welcome.
this was really informative, and I think we had a really good turnout with some good discussion. So I appreciate everyone for coming. Share this. I'm going to put it on our YouTube page. So share it with your friends. And actually was able to finalize. So we're going to talk about lymphedema next month. So mark your calendars for March 2nd. Lymphedema from a lymphedema certified therapist over in the Treasure Valley area. So it'll be exciting. So stay tuned for that announcement. And hopefully we'll see you guys all next month. I'm going to stop recording.